Good morning to all of you. Of course, it is actually a non-alcoholic fatty liver disease, NAFLD, an update. Uh, it's quite, as Madam said, it's a quite familiar thing for most of us, but there is a definition for this thing, non-alcoholic fatty liver disease. So it's defined as a histological and radiological presence of excess fat, what we call steatosis, in more than 5% of the hepatocytes in the absence of secondary causes. So this figure of 5% of the hepatocytes being involved with fat is important. And the secondary causes we have to exclude are alcohol and certain drugs like valproic acid, methotrexate, things like that, viral illnesses and certain metabolic conditions like polycystic ovarian syndrome. So you have to exclude all this to arrive at this diagnosis. But this is the definition which is important. When it comes to NASH, it's essentially a macrovesicular deposition of fat in the hepatocytes. So as soon as I say macrovesicular fat deposition, it will come to your mind, okay, there must be something like microvesicular fat deposition as well. Obviously, yes. The difference is when microvesicular fat deposition is there, they are tiny fat droplets and there would not be any change in the architecture of the hepatocytes. Whereas in macrovesicular fat deposition, the whole of the hepatocyte is filled with fat and even the nucleus is shifted. That's the difference. And what you see in NAFLD is actually macrovesicular fat deposition. So NAFLD is essentially a spectrum of disease where you start with non-alcoholic fatty liver and then through to the non-alcoholic steatohepatitis, fibrosis, which ends up in cirrhosis. So you have to bear in mind that this is a spectrum of disease which consists of all four entities. So this is actually a graphical illustration of what I have just said. In the left-hand side, you will see a healthy liver, and then you see the benign steatosis. So it's so common that in our community, about 25% of the people will be having benign steatosis. So proportion of that, roughly about 1/3, will go into have what we call the non-alcoholic steatohepatitis. And if we see a cross-section of the community at a given time, about 3 to 5% of the people in the community are actually having NASH. And out of those who are actually having NASH, 1/3 of the people will have associated fibrosis as well, what we call NASH and fibrosis. And then out of the people who have NASH and fibrosis, about 1/3 will go into have cirrhosis at the end. Right. So do we have to talk about this? As Madam said, it's a very common topic. So why should we waste our time talking about this? There are reasons for that. So the worldwide prevalence of NAFLD is actually at present is about 25. It has a wide variety of range. So it is about 13% in African countries and it's about 30% in Middle East countries. And in Europe, it has a middle figure like 23. So it's so common. And what we see today is the overall number of patients with, when you consider the overall number of patients who goes into end-stage liver disease, you see more and more people get it as a result of non-alcoholic fatty liver disease. So it's quite important. And other important issue is non-alcoholic fatty liver disease itself may be an independent risk factor for heart disease. So from there also, that has an important. So other important area is non-alcoholic fatty liver disease per se. Purely because somebody is having non-alcoholic fatty liver disease, they can, at one point, they can have hepatocellular carcinoma without going into cirrhosis. So because of all these things, yes, we have to talk about it. So I'll be enlightening you a bit about the natural history of non-alcoholic fatty liver disease. So it's important to remember that not all patients with non-alcoholic fatty liver disease progress to advanced liver disease. We have already gone through that graphical thing, so we know that. But up to 1/3 of people with non-alcoholic fatty liver disease can develop what we call progressive fibroinflammatory form of that, what we call non-alcoholic steatohepatitis, which is important. 1/3 of people with NAFLD go into have NASH. So NASH is essentially diagnosed by liver biopsy. And when that is reported, there will be few things they will be mentioning. They will be talking about steatosis. They would be talking about lobular inflammation. They would be talking about hepatocyte ballooning, and then, in fact, fibrosis. So all these things would be there in that report when you do the biopsy. So the presence is NASH is important because that is the key driver for the development of fibrosis, and we know that fibrosis in who has got, people who have got NASH, the rate of fibrosis is as twice as fast as those who have just got non-alcoholic fatty liver disease without a NASH. So if somebody is having NASH, the chances for them to go into further stages, to have the chances of them having the fibrosis quite fast. So the extent of fibrosis rather than the inflammation is predicting the life-threatening outcome. So what is important in this spectrum of disease is fibrosis. So fibrosis will, at the end of the day, determine cirrhosis, liver failure, hepatocellular carcinoma, and the mortality. So fibrosis is the key. That's what I want to highlight. So then it's understood that the main clinical objective is to identify those with fibrosis due to NASH who may be at a risk of significant liver disease. So pathogenesis of NASH is complex, and it involves kind of multi-hit thing. It's not a single thing. So there are so many things which are involved: age, sex, ethnicity, and genetic predisposition. Obviously, they talk about certain genes more than the others. And it is believed that the inflammatory trigger in NASH is probably related to the fat deposition, which is causing toxicity in the hepatocytes, as well as the effect of altered gut microflora. So these things are important. The strongest risk factor for NASH and fibrosis are the type 2 diabetes and related metabolic disorders, including obesity. So much so that now they are thinking of changing the name into metabolic related fatty liver disease from non-alcoholic fatty liver disease. So when it comes to the patient with established NASH, those with diabetes are at a greater risk of progression to end-stage liver disease and cancer. So diabetes is important when it comes to NASH. So just to recap the things what I have talked to you over the last few minutes. So when it comes to the pathogenesis, genetic and environmental things are important, certain genes more than the others. And the clinical features are there, things like obesity, diabetes, and dyslipidemia and hypertension. And then these pathogenic mechanisms like lipotoxicity, changing the microbial flora and innate immunity. All these things are important in bringing up this pathophysiology, right? So that's it. And now we are coming to talk about the important part of diagnosis. So diagnosis of non-alcoholic fatty liver disease, it's of actually twofold. First thing is identifying the steatosis, so that we know that they have got non-alcoholic fatty liver disease. So there are a set of things we do to find out whether the person has got steatosis, or in other words, non-alcoholic fatty liver disease. So once you do that, what you have to do is a risk stratification, so that you find out the presence of NASH and whether there is additional significant fibrosis. So first of all, you find out whether steatosis is there. You find out whether non-alcoholic fatty liver disease is there. As soon as you do that, you do the risk stratification to see whether there is a steatohepatitis and whether there is any associated significant fibrosis. So diagnosis of steatosis is essentially ultrasound based. It's the diagnostic modality of choice, but we have to remember that there is a drawback. So if you go back to our definition, it says when more than 5% of the hepatocytes are having fat deposition, it is called non-alcoholic fatty liver disease. But the sensitivity of ultrasound scan is not so good that it when you do the ultrasound, you might miss people who has get fatty liver with less than 20% of hepatocytes being involved with fat. So there is a chance that you will miss it, but still it's a diagnostic modality of choice. So alternatively, there are certain other validated serological markers to identify hepatic steatosis. So these things may be important, especially in areas where there is a limited access to ultrasound, etc. So I'll be talking to you about few validated serological markers to identify hepatic steatosis. So one thing is fatty liver index, then NAFLD fat score, what we call NAFLD FS, and hepatic steatosis index, HIS. So one important thing is when it comes to a non-alcoholic fatty liver disease investigation, we usually do that when we see somebody who is having deranged transaminases. But I want you to remember this point. So this approach is limited by the fact that many patients in that spectrum, that NAFLD spectrum, are actually having normal liver function test. So you have to remember that somebody can still have non-alcoholic fatty liver disease with normal liver function. So it's really important to have great index of suspicion. So you have to consider the possibility of non-alcoholic fatty liver disease when somebody is having type 2 diabetes or somebody is having metabolic syndrome, regardless of the transaminase level. So that you have to remember. So diagnosis of steatosis, we have already spoken about ultrasound and then these serological things. So fatty liver index, essentially it considers few things: BMI, waist circumference, triglyceride, and gamma glutamyl transfer. So very easy to calculate. And fatty liver index less than 30 practically rules out steatosis. Above 60 rules in steatosis, and the value, if it falls below 30 to 60, it's inconclusive of hepatic steatosis. And then this NAFLD fat liver score. So again, it considers metabolic syndrome, type 2 diabetes, fasting insulin, which is not commonly seen in our practice. I mean, we hardly do it because of the cost thing. Fasting serum AST and the AST-ALT ratio. Again, there's a cutoff value we have considered to diagnose steatosis and to rule out. Another thing is hepatic steatosis index. Again, all these are there online, so you can just have to feed, you have to just feed the data and you get the value. And there are certain cutoff values where you consider to decide on the presence of steatosis or not. Right. Right. So now we have talked about the part of identifying hepatic steatosis or non-alcoholic fatty liver disease. Either we have to do the ultrasound or we have to do relevant serological testing. So as soon as you identify that, as we have already discussed, the next important thing is risk stratification for the presence of NASH and the significant fibrosis. How do we do so? Right. NASH and fibrosis cannot be reliably and accurately diagnosed without having a liver biopsy. You have to have a liver biopsy to exactly find out whether there's non-alcoholic steatohepatitis or associated fibrosis. But we know practically, when it comes to the practical world, it's not feasible, not desirable to biopsy everyone with NAFLD because it's so common. And the other thing is the technique. I mean, liver biopsy is one thing, is invasive, and it incurs some cost, and the morbidity and in fact even the mortality is there. So they have devised a number of non-invasive tests that are calculated from routine collected clinical blood results that can give us an estimate of the risk of fibrosis. Okay, it's good if we can have the biopsy. If it is not possible, there should be other surrogate markers to find out the likelihood of fibrosis. So that's what we are going to do exactly. Right. So how we diagnose fibrosis? So there are serological tests for staging fibrosis. So one important thing is NAFLD fibrosis score, what we call NFS, and fibrosis 4. Then enhanced liver fibrosis score, what we call the ELF test. All these things are there to help us to decide on the degree of fibrosis of somebody who is having NAFLD. Right. So non-alcoholic fatty liver fibrosis score, there are 6 variables involved: age, hyperglycemia, body mass index, platelet count, albumin, and the AST-ALT ratio. So all these are actually found to be indicators of advanced fibrosis. So these 6 things are involved. So then they give a cutoff value where they identify significant fibrosis if that is above a particular cutoff value, and they rule out significant fibrosis if it is below a particular cutoff value. For index, this again uses a formula, and that formula should have age, AST, platelet count, and ALT. So it's very easy to calculate. Again, it has cutoff values, and if it is above a certain cutoff value, so that indicates significant fibrosis, and if it is below a particular cutoff value, it is suggestive that the fibrosis is minimal. Right. So these non-invasive test scores correlate well with the liver outcomes. So most of the international guidelines today recommend the use of non-invasive test of fibrosis as a screening tool to identify patients who are likely to have progressive liver disease. So without going to liver biopsy, you can use this non-invasive test to find out people who are having fibrosis and who are having a higher chance of progressing to liver disease. Right. So when you are doing so, it's recommended actually a two-tier approach. So use something simple like fibrosis index 4 or non-alcoholic fatty liver fibrosis score to rule out very unlikely people with fibrosis. So you do this, you calculate this score, and then you rule out the set of people who are highly unlikely to have significant fibrosis. Okay, now you have a set with the intermediate or high risk scores who are likely to have fibrosis. So you do a set of investigations and you rule out the people who are unlikely to have significant fibrosis, and then you get the people who are likely to have intermediate or higher risk of having fibrosis. So then for that category, you do a second tier of test, usually a set of biomarkers like alpha score or transient elastography, what we call fibroscan. And then you further refine them, and then you refer them for further diagnostic things as well as treatment. So that's how you usually approach these patients with non-alcoholic fatty liver disease. So few words about ELF test, enhanced liver fibrosis score. It essentially considers a few things, extracellular matrix markers, which consist of metalloproteinases, type 3 procollagen, and hyaluronic acid, all showing good correlation with fibrosis stages in chronic liver disease. So what you do in this ELF score is you combine quantitative serum concentration of these measurements to have a single value. And if your value is about 10.35, that's what they say, it suggests advanced liver fibrosis. The other important test you do to diagnose fibrosis at the second tier level is transient elastography. So the basic principle is transient elastography is that the propagation velocity of wave through a homogeneous tissue is proportional to its elasticity, which is correlated with the amount of fibrosis in the liver. So you have got a thing like this, you have got a vibrator, and then at the top of it there is a ultrasound beam. So when the vibrator vibrates, it causes an elastic shear wave, what you can see in red, and then that is followed by the ultrasound wave, and with the help of that you diagnose the stiffness of liver. So there is a formula for that, and based on that you can assess the degree of fibrosis. Right. So we are coming to the last few slides. So just to summarize what we have already talked about. So when you have got somebody with non-alcoholic fatty liver disease having diagnosis hepatic steatosis, what you do is you do simple tests like non-alcoholic fat liver fibrosis score or FIB4 to find out who are having a higher risk of fibrosis. If that risk is very low, what you do is you just monitor them once in 2 years. So if that risk is very high towards your right hand side, so you have to consider the liver biopsy. If the risk is intermediate, then you do the second tier testing to find out, to further refine the degree of risk. So when you do the second tier test, if their risk is low, I'm talking about this intermediate risk category. So when you do the second tier test, if they falls into low risk category, then again you monitor things once in 2 years. If they fall into intermediate or high risk category, when we do the second tier test, then again you consider liver biopsy. Right. Right. Thank you. So we are coming to the last bit, which is the management of non-alcoholic fatty liver disease. So there are a few key elements in the management of non-alcoholic fatty liver disease. Now we already know that there are so many metabolic things are involved. So they are having diabetes, they are having high lipid levels, they are having obesity. So obviously these people not die of chronic liver disease, but they die more of a cardiovascular related cause. So the chances of dying them due to a cardiovascular endpoint is as high as 40%. So it's important that we talk about the fibrosis and all, but it's essentially, it's really important that we modify their vascular risk factors. So we have to fix the blood pressure, we have to fix the lipids, we have to optimize the weight, we have to address the smoking, we have to control the diabetes well, and these are the cornerstones in management of non-alcoholic fatty liver disease. So it's important that you modify the cardiovascular risk factors fully. This important entity of diet and exercises. So intensive lifestyle changes can lead to improvement in serum transaminases and the markers of insulin resistant even without a weight loss. So when you go for intensive lifestyle changes, even if you don't lose weight, so there would be improvement in the transaminases and markers of insulin resistance. So we know that these things are important when it comes to the pathogenesis. So the histological endpoints of NASH resolution and improvement in fibrosis can be achieved with lifestyle-induced weight loss and are most frequently seen in those people who achieve more than 7% of the weight loss from their starting body weight. But we have to mind that it's really difficult to achieve that from one end, and even if we achieve, it's really difficult for people to maintain it. So these weight loss and achieving weight loss and maintaining it is important, but in practical life, this is something difficult to achieve for most of the patients. So there are newer approaches like bariatric surgery and found to be safe and effective therapy, and actually can result in dramatic weight loss. But the key point I need to highlight is, even if you don't have a significant weight loss, lifestyle changes are really, really important. And if you can have a significant weight loss, significant in the sense more than 7% from the starting body weight, then you can reverse the things to some extent. Right. So we come to the last few slides, pharmacotherapies. So actually hardly any treatment is actually proven for this. So vitamin E has shown some improvement in NASH. So that has been shown in the what we call PREVENCE study, and but there is a concern of a potential risk of hemorrhagic strokes and prostatic cancer when you give it for a longer period. And pioglitazone has been shown to be resolving NASH in the same study, but most of the people will have problematic weight gain with that. But importantly, neither of these have shown significant impact on the fibrosis. We know what is important in NASH is fibrosis more than everything, and there hasn't been any significant impact on the fibrosis after 96 weeks of treatment with both these agents. So these are being used, but lots of debates are being going on about the importance of them. The future is apparently going to be good, and there are newer classes of drugs are emerging for the treatment of NASH and fibrosis. So these agonists of what we call farnesoid X receptor, obeticholic acid, nuclear hormone receptor that regulates the bile acid metabolism. It has shown to protect against liver inflammation and fibrosis in murine models. The study is actually Regenerate, that was very recently done. And there are so many other drugs which are being used for the other purposes have been tested for this. So one such thing is GLP-1 receptor agonist, what we commonly know is liraglutide. There are 2 trials are going on with semaglutide and dulaglutide, which are in phase 3 and phase 4 trials currently for as a treatment option in a non-alcoholic fatty liver disease. There are so many other drugs which I have mentioned in green, very difficult to pronounce sometimes. So these are being tested, and to be frank, now there are about 40 drugs are being tested at different phases of the clinical trials regarding the efficacy in a non-alcoholic fatty liver disease. So that's it from my side. Thank you. And it actually takes my mind back to 2006, 2008 era, where we have been registrars at Colombo South. We have been struggling to do something for that weekly journal club. Professor Jayaratna, sir, you were there just as this, and we have been struggling to the questions what you have been asking. So I get that memory back. So thank you very much for helping us for this transformation. Thank you, everybody. Thanks, everybody, for listening to me. Thanks.
Thank you very much, Dr. Gamage, for that very interesting presentation, for making a complex topic sound so simple but interesting. We have 4 minutes for questions from the audience, so it's open to you all to clarify any doubts that you have from Dr. Gamage. Yes.
Yeah. So actually, when it comes to treatment of non-alcoholic fatty liver disease, treatment guidelines are not quite published. I mean, you don't have lots of treatment guidelines. So drugs-wise, up to date, when we talk about the current situation, they talk about vitamin E and pioglitazone. But other than that, so there is no proven thing apparently. Yeah. So to diagnose non-alcoholic fatty liver disease, so you have to have either histological or radiological evidence to suggest that more than 5% of the hepatocytes is filled with fat. So if that is there only, you diagnose non-alcoholic fatty liver disease. I don't think. So there was nothing in the literature I could found that there's a correlation between the stage of fat liver, what you see in ultrasound, and the extent of fat infiltration in the hepatocytes.
Thing where when we were registrars, especially at Ragama, there was a tendency where you said black coffee is of benefit. Is that still?
I actually don't know about that. So that was there, not there in the literature. So maybe a local thing. So might need some further kind of right frame of testing to find out whether there had been a significance in black coffee as a treatment thing, you say. So I'm not very sure about that. Yeah, but that was definitely not mentioned in the literature.
But our problem is actually, if you send any patient for a scan today,
yeah,
it comes back with the statement saying it's fatty liver.
Yeah.
So I think, it's rather than, we are not found really, although we got various drugs and various methods, we have really not got a drug that's really effective. And I think rather than screening, it should be a general educational thing to prevent the metabolic epidemic we are experiencing.
Yeah.
That's what you should strive for at the moment. I think, what do you comment on that? I think, what's your ideas about that?
Obviously, sir. Actually, now things have changed so much that actually, as I mentioned, they are going to even change the name of non-alcoholic fatty liver disease into metabolic-related fatty liver disease. So it's really important that, as you mentioned, that's what our local radiologists were actually talking to me in the morning. So they see about 60 to 70% patients who undergo ultrasound scans for certain other reasons, they have got fatty liver. So it's important that they mention it and you kind of diagnose it radiologically so that you can find out the things which you may have not detected yet. So the patient may be having things which are modifiable, that can be modified to have a better outcome. Things like undetected diabetes, undetected dyslipidemia, and other vascular risk factors, say obesity, which was not looked into. It's really important. The other important thing is, as I said, most of these patients with non-alcoholic fatty liver disease die of vascular endpoints related to all these things. So it's important that we modify thing as a whole, metabolic thing, as I said, and I'm in 100% agreement with that, actually.
So on that note, we'll have to thank Dr. Nilantha Gamage for an excellent presentation and excellent discussion. Thank you very much.